reaching over with
the faculty and the participants. Again, my name is Ted Schumann. I'm a rhinologist and skull-base surgeon at Virginia Commonwealth University in Richmond, Virginia. I'm also chair of the ARS Online Education Committee, and in that role, very happy to participate in bringing this idea to fruition. So I'd also like to take a moment just to thank our industry sponsors, Medtronic, for really putting on a fantastic course. Not only is this dissection facility wonderful, and as you'll see, we're going to really be able to learn a lot via the array of instrumentation and the quality of the video that we have set up, but also the logistics and pulling together a hybrid meeting involving people both in place and virtually from across the world is really amazing. So we're very appreciative of Medtronic's involvement in this. I'm just going to move things right along because I know we all are here to see the content and not listen to me talk. So very quickly, I'll start. I have the honor of introducing our first expert faculty member. Many, probably if not all of you, know or know of Dr. Brent Sr. He's a true world leader in our field. He is professor of otolaryngology, rhinology, and skull-base surgery at University of North Carolina at Chapel Hill, where he was one of my fellowship mentors. He has served in leadership positions on the American Rhinologic Society and just about any other society relevant to our practice, and has published, lectured, and further just provided educational content extensively. So we're extremely lucky to have Dr. Senior with us tonight or today. And with that, I'll pass it to Dr. Ed Kwan to introduce our second faculty member.
Hello, everybody. Thank you very much, Ted. Again, thank you all for being with us today, whatever time it is around the world, and we're very excited to have this event. My name is Ed Kwan. I'm from the University of California, Irvine. My role also is as the education coordinator of the ARS, and we're very honored to host this event jointly with the support of Medtronic. Now, I have the distinct honor of introducing our second esteemed faculty member who comes to us from Taipei, Taiwan. Dr. Shinpo Hao is from the Xingkong Wuhuoshi 纪念医院 affiliated with Furen Daxue, which is a world-class institution, and he is an expert in all aspects of otolaryngology and head and neck surgery, has with specific expertise in techniques such as nasopharyngectomy, which we're hoping to really see him showcase today. And it's going to be an exciting event in order to be able to see all these cutting-edge techniques, and these two experts almost do some dueling dissections and also some mutual support with each other in order to bounce ideas off each other. So we're really, really looking forward to this event. The event is going to have two components that we're going to bounce back and forth to. So Dr. Senior is going to be focusing on a lot more advanced sinus techniques that are going to be critical for not only inflammatory disease, but tumors and skull base as well. And then Dr. Howe is actually going to focus specifically on the nasopharyngectomy, as well as some of the coronal plane skull base dissections that are so critical for us, especially as we begin to further our frontiers in these surgical areas that have previously been thought to be unachievable. So without further ado, we're going to go ahead and turn it over to our expert faculty in order to talk about some of the preoperative imaging and considerations for their cadavers, and also for their thought process and other things they want to share with the audience. So let's go ahead and start with Dr. Senior. Dr. Senior, you able to hear us in there?
I hear you very well. Thank you, gentlemen. And it's a real honor for me to be able to be here tonight to be participating. And thanks so much to Medtronic for their support of us and being able to bring this course to fruition. The ARS is such an important organization in providing education in rhinology here in the United States, but also we want to be leaders in rhinology education around the world, and we welcome all of our participants from around the world here tonight. So I'm going to just start with going through my CT scan, and I have done some pre-dissection on my specimen here tonight. We have lots of things we wanted to try to cover. So I've actually already dissected this specimen's right side. And so we've done a fairly complete full house Fess, but not a sphenoid yet because I wanted to wait on that. But we've got it well started here, and I'll go through that in a few minutes as to exactly what we've done and what we've started. But I am going to start on this side, on the patient's left side, on the specimen's left side here. We have not dissected any of the sinus anatomy as of yet, but I'd like to focus on the CT scan and how I review my CT scan before I start my surgery. And what I'm concerned about as an initial point is I want to look at the slope, the shape of the skull base. And in particular, I want to look at the relationship of the cribriform and how oblique the orientation of the lateral lamellae of the cribriform are. And you can see as we go more posterior, the little lateral lamellae tend to become more oblique. In this particular specimen, the skull base height is fairly symmetric. It's slightly higher on the left side, but for the most part, fairly symmetric. But we are gaining a little obliqueness to the lateral lamella on both the left and right sides. And here on this cut on the coronal section, you can see the very thin lateral lamella medially and the much thicker frontal portion of the skull base there. And so it's really helpful for me to kind of get a sense of that before I start my dissection, and especially that height difference. If there's a real asymmetry in the height between the two sides, I find myself having muscle memory from one side to the other. And so I really need to be looking at that and thinking about that appropriately if there's a difference between the two sides. The next thing I look at is I look at the position of the anterior ethmoid artery. And in particular, I want to see how low it is hanging in the skull base. And we can see in this particular image here on the coronal section that it is hanging, it's at the skull base, but there is some supraorbital development above it. And so it is possible that the artery could become injured in a situation like this, particularly on the patient's left side, more so than on the right side. I also like to look at the relationship of the superior oblique muscle. I also like to look at the fat that's located in the mesentery or in the little dimpling of the anterior ethmoid artery. And in this case, we're using a cone beam scan, and it's a little difficult for me to make out the anatomy, so I can't really comment on that. But again, that's important for me to know and to look at ahead of time, because if I were to cause an injury to the artery, I would use a bipolar cautery to cauterize it. But we got to be really careful if we see on the scan that the muscle is really pushed into the dimple there of the anterior ethmoid. And so we just want to be very careful about that. And I have an idea of that because I've looked at the scan ahead of the surgery. I always have an idea of that during my case in case I did cause an injury and need to cauterize that. So next thing we look at is we look at the position of the uncinate process. And in this case, the uncinate has been removed on the specimen's right side, left side, the uncinate is intact. And here I'm looking at the rotation of the uncinate. And I want to see where it is, in particular with regard to the position of the orbit. I want to know how much, when I'm reaching over with my backbiter to remove the uncinate, I want to have a sense of how much room I have before I go over and touch the orbit. In some cases, the uncinate can be really plastered against the orbit. And I see this in particular when I'm doing, when I have a concha bullosa present. And so in those cases, I want to be aware of that and really peel the uncinate carefully off of the orbit, being aware that if I push my backbiter over lateral, that I could actually enter the orbit by doing that maneuver. I also want to look at the height of the posterior ethmoid in relationship to the maxillary height. And so here I am in the posterior ethmoids on the CT scan. We're losing part of the maxillary sinus, but we have an idea of the position of the height of the maxillary there. And I would call this a reasonably high posterior ethmoid, right? You know, you've got a fair bit of room back there. Now, admittedly, the scan is a little cockeyed, but for the most part, it looks like to me there's a fair bit of room there after I go through my basal lamella before I actually reach the skull base. So that's a helpful thing for me to have in mind as I'm dissecting, as I'm moving my dissection posterior. Next thing I look at is I look at any named cells. So I look for Haller cells. I look for anode sinuses. So in this case, we actually do see a little Haller cell here on the specimen's left side. Again, really just helpful to identify that ahead of time. Because that can be a little challenging if you didn't recognize that, and I would wonder why my maxillary looked a little funny as I'm opening it. So important to identify that ahead of time. And in this case, we're also going to look for some anode sinuses. So let's look posterior here. And it does look like we have anodes present on both the left and right sides. And you can see that because your sphenoid sinus is always going to be medial inferior, and I see a cell above the sphenoid sinus there. In fact, I see two of them on the left, on the specimen, actually on both sides. I see two cells there. And so that is going to be posterior ethmoid development pushing into the sphenoid sinus. And in this case, actually, if you look at your sagittal image here, you can see that our sphenoid is actually fairly under-pneumatized, right? We have a fairly thick wall over the pituitary there, over the sella, and then there's not much pneumatization of the below the sella. So we're gonna, in this case, I would expect the drilling would be a little bit heavier, a little bit thicker in this case, a little bit more challenging, and the landmark's not quite as good, unfortunately, as a result when we see that type of relationship. All right, and then the final thing that I look at is I look at the frontal outflow. And I want to see the cell development in the frontals, in the frontal recess specifically. So let's look at that for a second. So if you look at the sagittal image, you can get a sense of the auger development anteriorly there, and you have a little bit of you have an isolated auger, and it looks like we have a second cell above the auger there. You have a beautiful delineation of a pathway between the auger and the bulla. And that pathway tends to be the pathway where the frontal is going to drain, right? And typically, of course, we see that medially, but it really depends on how big these cells are. Now, as I'm kind of manipulating my suction, I'm watching my frontal and I'm seeing that frontal outflow there. And it's a beautiful track there coming down. And again, here, a real prominent single auger cell anteriorly. You see a bulla with a suprabullar cell posteriorly there. And so my frontal looks like it should be fairly wide, fairly accessible. And this pathway, if you look at the image guidance, looks like it's almost smack in the middle of the ethmoid there. So it's not really so much a medial opening, not so much a lateral opening. It's almost in the middle there where we're seeing the frontal outflow there. So that's helpful for me, again, as I'm doing my dissection to kind of get that sense as to where it's at. All right. Any questions, comments about that, gentlemen?
It's a beautiful walkthrough of the process, and I love how you did it systematically. So thank you so much for sharing that with us. One question that I had, just based on some of the information you discussed, is what is your technique of choice for removing Haller cells? Because they can be very challenging based on the angle and sometimes very hard to see and subtle. So do you have any tips and tricks to share with the audience?
So my favorite instrument for removing Hallers is the 90-degree Blake sleeve. And what I do in those situations is I rotate the 90 under the orbit with the base of the instrument up this direction, point it into the maxillary sinus, and I bite it that way. Mm-hmm. So I kind of, and I'll try to show, do we have a 90 actually on the set? We'll try to show that while I'm doing the ethmoid dissection. Once we get into the maxillary here, I'll try to show that and see if we can illustrate that well.
That would be awesome. Thank you.
Yeah, I agree with you though, Ed. It's, to me, the Haller cells are frankly some of the toughest for me. They always feel really uncomfortable when I'm going after them because you're really putting a lot of pressure on the orbit over there. So you have to be really, really aware of exactly where it is that you're working and where they're going to be located. All right, I like the backbiter. I use the backbiter technique for taking my uncinate down. So I'm going to take my pediatric backbiter, place it into the infundibulum, and take several bites at the junction of the uncinate where it makes that L shape. And that typically, I find that the maxillary ostium is almost at the level of the bottom of the bulla here. right? That's oftentimes where I find it. So that's where I'm kind of aiming my backbiter. I start to hit the heavy bone here. And so I'm going to stop as I get to the lacrimal here. And we'll get a J curette. And let me just pull out the superior part of it here and rotate that whole uncinate out. Take enough by placing. And we'll get that piece out, and then we'll go after our bulla. When I grab the uncinate, again, everyone does things differently. My approach is I grab this, I push in, pull down. And then I'm going to show you now. We have a beautiful view of the bulla here. I'm going to wait to do the inferior part of the uncinate because I like to do that with a 45-degree endoscope. But we're going to show the bulla. And when I remove my bulla, I typically do this with a J curette. And I place my J curette into the hiatus semilunaris superior and find the retrobullar recess. And there it is right there. See, my J is finding that space between the bulla and the basal lamella. And I'm going to start pulling that forward. So I'm kind of on the outside of the bulla, right? I'm not actually punching into the bulla so much as I'm actually coming around it and dissecting around the whole bulla. And the reason I like this approach is it's very complete. I can do an anterior ethmoid, a full bullaectomy here very, very quickly and very complete with minimal work here. And let's get our debrider. And I tend to use my curettes and things to do a lot of my dissection. And then I use the debrider for a lot of cleaning. But we got a lot of work to do tonight. So we're going to try to move through things. And so I'm going to be using the debrider a lot. Can you hear me okay with the debrider going?
Yes,
we sure can.
Okay. So I've actually gotten into the basal lamella here. You can see I've actually gone through it a little bit here. But let's get some of this superior part of the bulla as it's going up towards skull base. Remember, we saw a suprabullar cell heading up to the frontal.
Dr. Senior, can you comment a little bit about your technique for microdebrider or the settings you use, any specific things that you would recommend for any surgeons in using a microdebrider?
So I tend to like a microdebrider that I have to work. I don't want it to do all the work for me. You can see I'm really stroking the tissues here. I'm really manipulating the tissues. I don't want a debrider that I can just sort of jam in there and it suctions everything in and does all the. I want to be able to dissect with my debrider. So I use it I tend to use it at a setting of 5,000 RPM, so not a super high setting, because I think that allows the tissue to be brought into the debrider better and to function a little bit more. But the bottom line is you want to see where your blade is located all the time. And of course, when you get to the lamina here, which I'm on now, I'm going to be super careful. I'm watching the debrider very, very carefully as I'm operating on the lamina. And I use the edge of the debrider. I kind of catch the tines of the debrider. I catch it on these little bony edges, and it allows the bone to fracture. And so I'm using it to kind of almost curette the bone a little bit. Okay, so we've done a lot of work here in the anterior. We're gonna do a little bit more there in just a second. We'll do some of that with our angled scope. So let's go through our basal lamella now. So basal lamella, here's the horizontal portion, vertical portion rising up. So you can see we've already entered posterior ethmoid here. So we're gonna go ahead and now I like to get my posterior ethmoid a little bit, or my basal lamella a little low. I know a lot of people like to keep it kind of high, but I like it to kind of bring it down low.
Dr. Senior, as we come through the basal lamella, and maybe to spice up the conversation a little bit, historically, the discussion of whether or not to preserve middle turbinates has been one in which people have had strong opinions, and perhaps those opinions have changed somewhat through the years. I wonder if you could comment on what your philosophy is these days about middle turbinate preservation.
So I have modified my opinion over time. I do try to preserve at least a good part of the turbinate if at all possible, right? Obviously, a diseased turbinate needs to be removed. But if the turbinate is healthy, I tend to try to preserve at least a good part of it. That being said, I am removing very commonly at least half of it now. And the reason I'm doing that is because I feel like the literature is supporting that in terms of outcomes. But I also find that it does help maybe with topical drug delivery. I think that's a very legitimate argument to removing part of the turbinate to assist with topical drug delivery so that you get better deposition into the ethmoid and into the cavity. So very different than the way I was trained, very different than the way I maybe even taught you, Ted, but I'm taking more turbinates now than I ever did in my life, that's for sure.
I can't believe it.
I know. Shield your ears, young children. But I don't do it. I don't want to be flippant about it, again, because I do respect the fact that, again, we know that there's olfactory fibers here. We know that this is, it's a vital living structure, and we don't want to just be willy-nilly about it. So that's where I'm saying I do believe that we should be preserving superior portion of it. And I don't find it a big issue. I haven't had any issues really with lateralization or anything that we always used to talk about. I think good post-op care eliminates that concern as well.
The data has I think, as you alluded to, has kind of argued against empty nose syndrome as being a sequelae of routine middle turbinate removal. I'm wondering if in situations, if you need to take out part of the inferior turbinate, such as a mega antrostomy, does that change how you approach the idea of taking out part of the middle turbinate as well?
Honestly, I'm trying to be conservative regardless, but it doesn't necessarily. Though there may be exceptions to that, I would say, and it might be patient dependent to some degree. But I think it's a reasonable concern. And so, again, just as I said before, I wouldn't want to be flippant about it. That's for sure. So I continue. I got to be honest with you. I mean, I've been doing this a long time, and I continue to be humbled by what I'm doing. I always feel like I'm learning new things all the time, and I encourage all of my residents and fellows to always be open to new ideas and to learn new techniques, and not to be really very dogmatic, because things we're dogmatic about today, we may find tomorrow are kind of silly. So be open to new ideas and learning new things. Okay. Here I've been dawdling. I'm sorry. I got so caught up in the conversation.
Perhaps later, if we have the opportunity, you could show us your technique for middle turbinate partial resection.
Yeah, I will in just a few minutes, actually. And of course, normally I would do that at the beginning of the case, but I really wanted to illustrate how we want to do our ethmoid without taking a turbinate if possible. But I'm going to take it in a minute anyway, because I think it'll help with some of our other procedures we're doing here today as well. And as you saw on the other side, when I looked in, I already took it on the other side. Okay, so one thing now, as I've done my posterior ethmoid dissection here, the next landmark that I'm looking for is my superior turbinate. And here we have a nice view of my superior turbinate in the transethmoid approach, right? And my superior turbinate is key because now this is going to take me safely into my sphenoid sinus. And let me go ahead and just show with the suction. We place our suction here into the sphenoethmoid recess, into the space between the superior turbinate and the septum, and there's our sphenoid ostium, right? And so that's a very consistent landmark. You can rely on the fact that you're going to be finding your ostium in that area. So let's go ahead and hit here again. Now, again, not to be too flippant, but I'm going to remove the inferior part of the superior turb. Again, we know there are olfactory fibers here, no doubt about it, but I'm trying to preserve at least the superior portion of it at this point. And that's a fairly typical appearance to the ostium too, where it's kind of slit-like.
A really great view and anatomic relationship that you have there right now.
Now, remember, we said there wasn't a node sinus here. And so here, if you look here, we're right here in this space, we're behind the sphenoid ostium, right? So this is that posterior ethmoid node sinus that we were seeing on our scan right here. And there's our ostium right there. Let's get a coddle. And I'm just going to slide a little J curette into the ostium and bring it down. Just dilate this a little bit. And I like to, before I actually go and start removing all of this, I always like to peek in the sinus real quick, just to kind of give myself a general idea of where all the anatomy is there and where the periphery of the sinus is. And I'm actually going to use the debrider here because I know where the wall is, I know where things are, and I'm placing my debrider here just at the ostium. And I'll always want to, again, look and peek in before we do any debriding in any sort of dangerous location here.
I was going to ask you.
We can use Kerrisons here. We can use mushroom punches to widely open this as well.
I was going to ask you, and you already started doing it, but how do you manage the inferior aspect of the sphenoidotomy regarding the posterior septal branch of the sphenopalatine?
Yeah, so I am a little conservative going down, but obviously if sometimes the shape of the sinus is such that inevitably you do potentially injure it. And obviously, if you do experience a bleed from the posterior septal artery there, you need to cauterize it. There's no other way around it. It's a big artery, and it's going to bleed a lot, and it'll cause a post-op bleed, most likely in the recovery room if you don't cauterize it right now. Mm-hmm. So I try to avoid doing that, but occasionally it happens inevitably, right? And you just have to be aware of it and cauterize it. If I'm doing skull-based surgery, obviously it's a little different, right? Because we want to preserve it for potential flap. And in those cases there, shield your eyes. My goodness, we got a lot of stripping. I don't like to strip mucosa. That's a specimen problem. It's not me.
You're actually just prepping for the later parts.
Exactly. But this is an opportunity here. Look at this now. Look at the beautiful anatomy here, guys. Look at these olfactory philia coming down on the skull base here. You can see the beautiful tracks of all the philia coming down onto the superior turbinate here. Yeah. So, I mean, that was my point. That's why I stripped all that out, to just show you that anatomy.
Excellent.
All right. So anyway, so when I do when I'm doing skull-based work, I tend to use a coddle, and I tend to push this down a little bit, try to get the mucosa off of that bone. And as I'm bringing the bone inferior, I'm trying to push the artery out of the way so that I'm not going to cut through it as I'm doing right. Interestingly, the bone on this cadaver specimen is very, very thin. It's kind of wispy in places, and you can see that's why I created a little perforation here as I was trying to lift a little flap on the other side. It's a challenging, kind of a Kerrison down, a little bit challenging the tissues here. Again, I'm blaming on the tissues, not my technique.
Of course. Dr. Senior, as we're talking about hemostasis, I was wondering if you could tell us what your thoughts are on, or what your routine regimen for hemostasis is these days for your routine Fess cases, or if you have any tips or insights for the audience on optimizing the surgical view.
Yeah, so a couple things I think are really important. One is I think head position is super critical. And I like to have the patient's head reasonably elevated, to whatever level I can. So I do try to encourage that. I think all of the studies really emphasize the fact that having the head elevated is going to be effective at reducing bleeding. The second thing I believe in, and probably one of the biggest changes in my practice over the years, has been topical epinephrine. I really was very scared to use it initially, but when it's used properly and when you're careful with it and use it appropriately, it can be incredibly helpful at reducing your bleeding. So I love topical 1 to 1,000 epinephrine. I respect it tremendously because it is a dangerous chemical, right? But again, when used correctly, it's extremely helpful for us with our dissections, I find. And then the third thing I'm doing, and I'm not sure how much it helps. I've been pretty convinced it's kind of either yes or no, it does. There's not like a lot of middle ground for patients, but that's TXA. I've been using a lot of tranexamic acid for patients, and I think it helps. I think the data is supporting it in general. I mean, there's plus minus in the data out there, but kind of a straight truth. But there's so little downside to it. That's the reason I use it pretty consistently. And I'm using it IV, 1 gram IV at the start of the operation.
Yeah. So it looks like you switched over to the 45-degree scope now. And
yeah, you're doing I like to. The reason for this is because I really, really want to see my natural ostium. I get the large one of the maxillary sinus. I know that I removed the unsent and everything, but I really want to prove to myself that I'm not going to cause a recirculation. So, for example, here I go. If I didn't have my 45, that little bar right there, I wouldn't have necessarily seen that little bar as I'm enlarging the sinus. I can see that I got the natural ostium anteriorly with the zero scope. I can just sort of basically see it in my peripheral vision there, but I wouldn't necessarily see that bar there. So, again, that's why I take the extra couple moments here and make sure that I can see it really well, and I'll make sure that little band is gone as well.
And that really can be the difference between a successful surgery and an unsuccessful surgery too. So that's an amazing view. Dr. Senior, we did have a question from the audience about the role of topical TXA. Is that something you've worked with, or what are your thoughts on that as an adjunct? I'd
be curious what you guys think. I truly haven't done it. I haven't been convinced by the literature on it, so that's the reason I haven't. I don't have a lot of experience with it. The couple times I've done it, I wasn't necessarily impressed, but obviously, ERs are doing it pretty routinely for tonsil stuff and what have you. So there is some belief that topical does seem to have some effect. What do you guys think on that?
I personally don't have a lot of experience with it. I think topical epinephrine works really well, like you mentioned. So it's been more than sufficient for the vast majority of cases. How about you, Ted?
Yeah, I would agree. I know that our residents love it when they're on call, that it's moved from being used for tonsil bleeds to all sorts of different tumor bleeds and other sorts of issues. So I know that it is growing in popularity. I personally have not used it in the OR for similar reasons, that I feel like between topical epi, warm saline irrigations, head of bed elevated, blood pressure control, and then TXA, it just hasn't been necessary to go to that point. But certainly be curious if anyone wants to leave in the comments any ideas that they have about how they've been using it. That would be interesting.
This is that Howler cell 90-degree technique.
Yeah. Sorry, you guys were talking, and here I went and did it. But yeah, that's what I like to do. So I'll show again how I did that. I just reach over with the base of the 90-degree forceps, kind of pointed up toward the middle meatus there, and I place the instrument into the sinus. So I'm kind of not reaching up with the instrument, right? Because I want to avoid the floor of the orbit. I want to kind of grasp it and kind of grab the contents, grab the entire cell if possible with the instrument. And I find that's a safe way and fairly effective at getting the cell open. The 90, I love the 90 Blakesley. the 90 Blakesley shocks you with how well it cuts the tissue and how well it can cut through bone. It's a great little instrument. I use it a lot. I really like it. So, okay,
Yeah.
So we've done pretty well there, I think, with that maxillary. So let's finish up with our frontal on this side. And we did quite a bit there. We knew, can I have the curette, the frontal curette? Remember we saw a large auger cell. Yep. And then there was the bulla and the suprabular. So we're through the bulla, suprabular. Here's that transition space between the auger and the bulla. And here's this beautiful, big, huge auger cell here. And so we're just going to place our curette up into that transition space right there. And it goes right up into the frontal.
That's a fantastic view.
Thank you, Ted.
You're welcome. I have to say that because, I was his fellow, but I do also think that it's a fantastic view. Both things can be true at the same time.
Okay, can the angle debrider? We'll go ahead and just finish opening that, the angle. We'll transition over to an angle debrider to finish that up. And then maybe what I'll do is I'll take us to the other side and I'll show you some of the work. I wanted to do a draft 3. Also wanted to show you some maxillary procedures and some extended maxillary, but also we're trying to do a pituitary. So let me just show you what I've been doing on the other side. I'll transition over there after we finish this frontal.
Sounds good.
How we doing time-wise? Should I...
We're thinking of, at some point, also transitioning over to Dr. Howe to talk a little bit about his scan as well. So just let us know when's a good transition point.
Yeah, let me finish this up real quick. I was complaining to the guys here earlier. We didn't have my favorite frontal instrument available tonight, unfortunately, and that's my Hosemon forceps. So I have to fake it here. I love the rotating debrider. Being able to rotate this tip around in different directions. Of course, you got to be safe, right? Posterior can be particularly challenging. But again, you're watching that tip. You're seeing that tip grab what it's grabbing there. And we're able to rotate it around there and get these little septations, clean this thing up a little bit more. Again, I'm using, just like I was doing it with the straight debrider, I'm kind of using the serrations on the side of the debrider to kind of catch the bone and curette it a little bit here. And swing over to the other side.
What size micro debrider is that? What's the diameter of the blade?
This is but what's the diameter? It's a 3/4.
Okay. I love
while you're using the 45 degrees. If you can also point out the anterior ethmoid artery for our audience as well.
Oh, yeah. Sorry, man. Yeah, I forgot to do that for you. And it's a beautiful view of it right there, right? And there we are. So remember, when we're seeing it, it oftentimes courses across the skull base, anterior medial, posterior lateral. So I'm looking for little septations over the skull base that kind of have that orientation. And that kind of gives me the warning sign that I'm getting close to it. Anterior medial, posterior lateral. And again, it's rarely at the frontal itself. It's just like a cell behind it. So it's not at that first basal lamella. It's in that transition area is where you often see it. You don't see it right at the frontal. Okay.
Dr. Senior, on that topic, just very quickly, I was wondering if you could talk about, hypothetically speaking, of course, if a wayward resident or fellow or somehow does get an anterior ethmoid artery injury intraoperatively, what is your preferred way of dealing with that? And on top of that, I guess we could differentiate between that being a more medial injury or a more lateral injury where it does start to withdraw into the orbital cavity itself.
Yeah. So a couple things. One is your bipolar is your friend. A bayonet is really hard, I find, to get up here, so I do rely on my endoscopic bipolars. Now, the reality is that a lot of times they're not open and set up, but I always insist that I have the set with the endoscopic bipolars sitting in the room, and at least so that I can hook it up real quickly. So that's kind of my rule in my OR. A medial is not a big deal, right? You have a lot of room there to go ahead and potentially get the bipolar on it. Lateral, more challenging. And that's where I've looked at the CT scan ahead of time to kind of see how aggressive I can be here. You know, I mean, I can do a bipolar here, but if there's muscle in here, if the superior oblique is kind of squished into this little dimple right here, I could still cause permanent double vision for the patient. So I'm going to be a little bit potentially more conservative if that's the case, and I'd be a little more cautious. And I do occasionally, I mean, thank goodness this doesn't happen often, but it will happen to everyone at some point. And I will use a little topical epinephrine to stop the bleeding, especially if there's any delay. And I do that because I understand it's going into spasm. It's not solving the problem, but I don't want the vessel to retract and to be actively pumping inside the orbit. So if I see that there's bleeding, I actually do place a little epi on it and get my bipolar out to give me a little bit of time. It's rare that it completely stops the bleeding, right? But it does slow it down a lot. I can see it to be able to cauterize it. It's okay. Okay, so we have a decent frontal here. We'll go ahead and trim that up a little bit more. Why don't we pass it over to Peter now and let him go through his scan, and I'll then take it back and we'll do some work. I'll do a little bit of work up here and maybe take us back to the pituitary a little bit, do some things here, get us ready for it while he's showing you the scan.
Perfect. Sounds good. Thank you so much. All right. Professor, how can you hear us?
Yes, very clear.
All right. Thank you so much again for joining us. And we're going to do the pre-scan review for your part of the dissection. So go ahead and walk us through what you're seeing and your surgical steps for your nasopharyngectomy or anything you want to tell us about.
Okay, thank you. And so Dr. Simple Ho from Taiwan. And so the setup is I actually do a pre-dissection on the right side of the nose. And but I did some of the bone structure and for the last step. And so I'm going to use the left side, and this is the nasoseptal prop I have been using, and I will just show you the anatomy of the nasopharynx. You could see this is the so-called fossa of Rosamuna, and this is the eustachian tube and the eustachian tube opening. And then you could see the porus tubalis here, and actually it's the continuation of the lateral nasal wall, which is the pterygoid plate face. Pterygoid plate, lateral pterygoid plate continuation, and so that we have the middle turbinate here. We have the middle turbinate here, and we have the pleura here, and there's a polyp here, supposed to be a superior turbinate. So you see the anatomy of the nasopharynx. You could see the sphenoid would be, on top, and the later surrounded by the later pterygoid plate, and also inferiorly by the subpalate, the upper surface, superior surface of the subpalate. And of course, the posterior wall of the nasopharynx will compose of the mucosa as well as the so-called pharyngeal fascia. So when we talk about the nasopharyngectomy, the surgery is initially, designed for a recurrent nasopharyngeal carcinoma. And of course, I think everybody here knows that nasopharyngeal carcinoma is a squamous cell carcinoma rising from the here the fossa of Rosamuna, and the direction of the extent will be actually through the so-called sinus Morgani. You can see that's the fossa Rosamuna fossa, and fossa Rosamuna, and actually that's a natural orifice through the superior contractile muscle as well as the pharyngeal fascia, and then go through this operation would be the eustachian tube, along with the muscle attached to the eustachian tube, which is the tensor paratini. So that's the natural extension of the MPC. So when we talk about the nasopharyngectomy, we need to remove all the tissue around this area, including the torus tubaris, as well as some of the later medial pterygoid plate, and tear down the sphenoid sinus floor and cut the mucosa till the contralator and then do a inferior resection, and then remove all this spacemen as to do an abrupt resection. And how we could do it? Typically, we would use. I'm going to use the contralator side. Use the right side for some of the surgical steps. The first step would be, first of all, would be to remove the middle turbinate. So to remove the middle turbinate is actually the nasopharynx is very deep in the center of the skull, so you could see it's very deep, and so it will be hindered by some of the structures. So the first thing is to create the so-called corridor. To create a corridor, you could actually remove some of the lower part of the middle turbinate, so that until you reach the anterior wall of the sphenoid sinus, where you find the sphenoid sinus os here, and you enlarge the sphenoid os, and you check for some of the critical structures inside the sphenoid, which is very important. For example, for your surgical dissection, for example, this is the internal carotid artery we find here, and this is the optic nerve here. And so this is enlarged sphenoid sinus. And then we typically use a transpterygoid approaches. How we did that, we typically enlarge the natural orifice that we show on the contralateral side. We find the natural orifice of the maxillary sinus and enlarge the natural orifice and do a medial maxillectomy like this. Do a medial maxillectomy like this, and we really go down to the inferior wall of the maxillary sinus antrum. And then this is kind of dirty. And then you did a medial maxillectomy, and you find the posterior wall of the maxillary sinus, and you find the bone between the. I intentionally left a piece of bone over the so-called pterygomaxillary feature. The feature that would be internal maxillary artery and the sphenopalatine artery and some of the nerves, including the median nerve and the infraorbital nerve, to go to the foramen noctandum, which is very useful landmarks for you to decide the anatomy location. So this is the so I'm going to remove the last piece of the bone. So I have a so when I remove this, you could see the structure. You could see the structure from the lateral to the media, which is the structure between the pterygoid plate at the back and then the posterior antrum wall. And so this comes through the sphenopalatine artery and the sphenopalatine ganglion. And you could see some of the vessels, the descending palatine artery here is actually here. And then you could see, you further go down and check down the mucosa. Could I have a dissector? Yeah. You further recheck down the, you could see that's the Vivian canal, which is very important landmark to localize your pictures, to localize the second genuine of the internal carotid artery, and the Vivian nerve will give you to the internal carotid artery, which you need to take care of when you, at least you know where it is when you do every nasopharyngectomy. And so this is particularly the pterygoid plate, which is the lateral pterygoid plate, which is the lateral boundary of the nasopharynx. And this retractome will really take you to the roof of the nasopharynx. And you would need to remove this. Look at the anatomy here. You really need to remove as far posterior for the lateral pterygoid, medial pterygoid plate, and so that you could get into the nasopharynx. And here I did some mucosa cut here, and just to show you the other very important muscular landmark, which is the saphengal pharyngeus muscle, so that it will form the inferior boundary for your surgical dissection. So we pretty much do this, and then I will keep on doing, and then after developing the contralateral nasal septal flap, which is for lateral reconstruction, you could actually remove the nasal septum here, and so that remove the nasal septum here, and then I'm going to remove the cartilage here, and then you could have the so-called panoramic view. That means it could work on this right side, but your scope come in from the contralateral side, so you could have your assistant to help you to do the nasopharyngectomy, because when you start to remove the bone and cut the muscle, cut the mucosa muscle, you really need your assistant to check the tumor really seriously, so that you could tear the tumor, take the tumor off the so-called, you see the pharyngeal fascia here, that's a very top fascia here. So that's the posterior limit of the your surgical dissection. So that you can see this will be, so I will remove the rostrum here and to get access to the contralateral sphenoid sinus, and at the same time remove the cartilage here, and so that you could see from left side and to check on the right side like this, and then you have a very good view of the nasopharynx, and you just do your mucosa cut, do your mucosa, remove the bone here, and do your mucosa cut, and then you will come to the lower fossa, and then you want to really tether down. After I remove the pterygoid plate, remove the rostrum, you could really get into the sphenoid sinus and really going down, just puncture out or drill out some of the sphenoid sinus, and it will be in the roof for the nasopharynx, and then you remove everything, cut the contralateral mucosa like this, and then you could remove all the surgical space. So that's the basic step for the nasopharyngectomy. Yes. Is there any question or?
Yeah, thank you so much for walking us through that. And I think you're going to showcase it later on as well when you actually remove part of the specimen. But I wanted to ask about the justification for reconstruction. What is the advantage in your experience of using a nasal septal flap to reconstruct the area versus letting it granulate? I can see one of the advantages is carotid coverage, but just wanted to get your thoughts on that.
Yeah, you see, I think it's useful because most of the nasopharyngectomy case would be carry on for the patient with a recurrent nasopharyngeal carcinoma, which has been heavily irradiated up to around 6,800 rods, and so that really needs something to cover the defect, and the nasal septal flap would be ideal flap to cover that. But however, you need to sure that there is no cancer invasion, because to the contralateral septum and the contralateral sphenoids, ethmoid recess, so that you could keep the internal maxillary artery intact, and then you could keep the posterior septal branch intact, so that you could use the flap. So that's the one of some of the considerations. We used to leave it open for secondary regeneration and for years, but usually the mucosa would regenerate within about 6 months. So definitely you need to do a lot of local treatment, a lot of debridement to help the patient to keep the nasopharynx hygiene so that they have good recovery, good regeneration of the frog. So that's the, yep.
Dr.
Got
Halbert,
it.
I was wondering
Yes.
if you could comment on how you select patients for endoscopic nasopharyngectomy. I know that you mentioned that radiation is first-line treatment. In your hands and your experience, are there certain factors that make this not an appropriate surgery to offer to a patient? And basically what I'm getting at is sort of what are the limits of how far you will take this approach before you look at other approaches or consider it non-operative?
Yeah, and to answer your question, first of all, you have to know the extent of resection and the way the high-grade malignancy was extend. Usually the tumor over the nasopharynx is in the fossa lower fossa of lower, and it will go along with the esophageal tube through the sinus Morgani, and later we will see that. Yeah, and then it really go beyond the sinus Morgani to get into the later parts of the medial pterygoid. And then here's the pterygoid muscle. And there's actually seems to me there is no real good surgical margins over the so-called parapharyngeal space. So that we try to avoid do surgery on this. And then again, you could see the other way of tumor extension is actually through the skull base, the pterygoid, the so-called pterygoid base here. But however, the bone is very thick here. And if you break through the bone here, you will go up to the basic, to the sphenosinus floor, and you will involve the second genuine of the internal carotid artery and may go, because it go this way and go up this way. So it might just involve the transverse portion of the internal carotid artery as well. And so there is actually no margin around the internal carotid artery. Of course, we could carotid artery, usually they would very soon to develop some distant metastasis, usually 30% within 1 year. So it seems to me it's not too, and you whenever you do some skull-base dissection to deal with the internal carotid artery, the patient would actually run a very pretty high risk. Don't forget they are actually a patient after radiation therapy, so we try to avoid that as well. So that's that means the for the endoscopic nasopharyngectomy is best for T1 or limited T3. That means the skull base, the pterygoid base, bone involvement, that would be a feasible case. But then if we really go to the across the sinus Morgani, go along the esophageal tube to go into the parapharyngeal space, it's not really a good surgical candidate. And then the real, the extent of resection will be the lateral pterygoid plate here. The lateral pterygoid plate here, it will be very difficult for you to do endoscopic resection from media to later. And so you probably need to use 45-degree scope or even 70-degree scope to see, and then there is no soft tissue margin. So we try to avoid that. So typically for endoscopic nasopharyngectomy, the best indication would be recurrent T1, although it's in the lower fossa, that would be all right. And some of the T3 involved in the skull base bone here, and some of the very minimal extension through the later to the medial pterygoid plate to involve the soft tissue here. And so that's the indication. However, when you expand your indication for endoscopic nasopharyngectomy, for example, in cooler cases with T2 or even T3 cases, your survival, your local control rate will be decreased. Yeah.
Thank you. That was great.
Yes.
Along those same lines with regards to resectability, how do you think about bony invasion? Does that ever deter you from offering a nasopharyngectomy, or what is your strategy for considering margins when it has over bony invasion on radiographic evidence of that?
Well, you see, the problem for bone invasion is that we cannot really control the bone invasion, the margin of the bone during the surgery. It's difficult to control the bone invasion, and I think I think the most important impact factor on the local control and survival would be the margin status, which we for recurrent nasopharynx cancer, we really need to take the most later part of the estrogen tube, the sinus Morgani, to the later control of the margin here. But whenever you involve the bone, it really depends on your clinical judgment, because you will drill the bone and you could clearly see if the bone is involved or not. And if the bone is involved, you just remove as much bone as possible. Yeah.
Got it. Thank you. So what your next steps on this is, are you already ready to start taking out the specimen, or you have more dissection?
No, I'm going to cut the spinal parting artery here, and I'm going to remove the bone. I'm going to remove the bone here and connecting the sphenoid, the rostrum here, and to see the panoramic view of the sphenoid, and then I will start to do the mucosa cutting, and then I would love to show the pharyngobasal fascia, which is a very important margin fascia for the margin control. And I need some time, so probably I would return this back to Senior for his work, and I will work on this.
Okay.
All right.
That sounds perfect. Thank you, Professor Hao. Yep. All right, we'll go back to Dr. Senior and check out what he's been doing.
That's how I remove the phone. Yeah, with the.
All right. So yeah, I've been doing a little bit of work, and so we finished our frontal, and I've started a draft 3. I wanted to do a 2B to help show you a little bit of the anatomy here. And we've taken the middle turbinate, and we've taken it back pretty far. Can I have a curved section? Or I can use this. Let me just get this section adjusted here.
Dr. Senior, we had a quick question from the audience.
Yeah.
Which endoscopic, is there a particular endoscopic bipolar that you like to use for specifically with regard to the anterior ethmoid artery control?
So I use the ones from, and again, I don't have any interest in any company here, but I use the Calvian type. It's endoscopic bipolar from Calvian. So here I've taken I've used my Kerrison forceps and my punches to bring the frontal sinusotomy over anteriorly as far as possible and anterior medial. I've removed the middle turbinate in the area of the frontal, and I've intentionally been a little aggressive about this because I wanted to try to see if I could show you the full olfactory philia coming down. I haven't been able to see it real clearly at the level of the frontal, but we want to take this down to the level of the olfactory philia. Sometimes I think that I see it, and I don't really. It's like a little bit of a unicorn for me sometimes when I'm doing a draft 3, but I do see some. I definitely see it here in the middle turbinate. Again, we clearly see the philia coming down here, but I just want to take it back to the back edge here of the frontal when I'm creating my septal perforation and taking my turbinate down here to get my draft 3 widely opened up. So what I'm going to do here, I've again made my perforation here. I've already taken the turbinate, and now on the other side, I've preserved my turbinate to just kind of show you the way I take this down. So let's get a straight true cut. I'm going to take this. Well, there's 2 things I want to point out. One is I want to show you how I take the turbinate down, but the other thing is I've already started the so-called slap flap on this side. So what I'm doing is I'm creating a medially based flap here that's pedicled right at the junction of the middle turbinate, the takeoff of the middle turbinate. And I bring it down essentially over the nasal lacrimal. That's what I'm doing.
Yeah.
And let me just show you how that looks now.
Yeah, I'm sorry, I forgot to introduce you. I'm kind of nervous.
There we go. And it kind of, so we're going to tuck this up and get it out of the way and try to preserve this. And this is going to be a pedicle flap that we're going to use to kind of reline some of what we're doing with our raw bone that we create with the draft 3. And it's sticky. Wait.
The inferior extent of that flap goes down to just above the inferior turbinate you mentioned?
Yeah, I took it actually into the inferior turbinate. It really, you can bring it all the way down as far as you want to be able to get coverage. So if you're really looking to cover a lot of the bone, bring it down lower. You can see I took it down just to the top of the inferior turbinate, but you can take it down into the inferior turbinate safely, no problem at all, and get a nice long flap. And I've really come to like this flap a lot for relining the bare bone that I create when I'm drilling the draft 3. If you don't do a pedicle flap like this, I do find a free graft is also pretty effective. I love free tissue off the floor of the nose, so I'll just grab a big postage stamp sized piece of tissue off the floor sometimes, and I'll place it up here. And then I'll use a little stent at the end of the case to kind of keep it in position and allow it to heal in. So let me just show you how, okay, I'm protecting my flap there. I'm going to go ahead and take the middle turbinate on this side. And let's see, we want to be careful. Flap.
So your technique is to use the through cut.
Yeah, I love through cuts because, again, I can be pretty precise with what I like to do here.
Absolutely.
And I can take it exactly where I want it to go. And then obviously anteriorly here, we take it up. Okay, and now we're ready to go ahead and get our drills, I think. Let's go ahead and change over to 45 scope, and let's just get those two sides together, and then we'll have our nice draft 3 opening. Let's get a see.
Do you have a preference for using curved drills, or do you like to use a little bit more of a straight drill approach, or just whatever you got in the set?
Well, no, I actually do like the curved drill. So I'm using, this is 60, is that right? This is 70 degree. This is 70 degree. I like the little mushroom head on it. It's a diamond. And I tend to, I drill from both sides. So I tend to place my scope on one side, and then I'll drill on the opposite side to kind of, this kind of keeps my scope clean. And when we're doing this, of course, we want to emphasize anterior. You want to bring this anterior wall and make it as smooth as possible.
Do you use cutting or diamond burrs? And then
this is a diamond. This is at
30K.
Yeah, this is the 30. And I do try to do as much with hand instruments as possible. So I tend to use my Hosemon forceps, and I have Cobras and things like that I'm going to use. And I'm going to try to do as much of the dissection with those instruments to start. And the reason I do that is it just makes everything so much quicker, right? I'm already here, 80% through my draft 3, and I just got my drill out. So we're going to take our inner sinus septum down. And we need to get a little bit of the septum here.
Do you change the position of the head?
I have not, but it can be helpful. You're exactly right. I have the head cocked pretty far back. So you do need the chin kind of up in the air as much as possible to get to, and sometimes, doing that, it's a great point, because sometimes doing that, you can actually do all of this with a zero scope. But I got to be honest, some of our patients are just of a size where it's really difficult to do that. So
right.
You just have difficulty going ahead and cocking the head that far back. So, of course, medially is where the problems occur. That's where we get our CSF leaks. So you have to be super careful as you're drilling this area. And this is where we're looking for our olfactory philia coming down.
Do you have any tips and tricks to share with the audience on how posterior or superior to go in this medial area?
Yeah, I have to be honest. I'm always looking at the sinus itself, and I'm looking at the shape of the sinus here. So that's what I'm focused on more than anything. Do you have anything specific you do, Ed?
There's that, we call it, I guess, the frontal T. So we try to,
yes.
Which is kind of where the olfactory philia kind of lay laterally. So then when you see the T, I just try to drill it back as much as possible, and enough so that at least the mucosa can redrape back.
That's a great point. That is an excellent one. Ted, do you do anything special up there to kind of define that?
Nope, just the way you're doing it. Dr. Senior, how do you approach making the superior septectomy? How large of a septectomy do you make, and what landmarks do you typically use to design that part of the draft 3?
So I tend to do the septectomy kind of late. I like to get my kind of the sinus opened on either side first before I actually do my septectomy. And then I actually, again, by looking at the size and the position of the frontal, I actually design the septectomy to match what I'm seeing as I'm looking up into the frontal. So I don't do my septectomy early. I actually do it kind of late. And you can see I'm doing this as a more traditional, find the frontal through the ethmoid. I'm not doing this as like an outside in type approach like the Australians will do, for example. I do it more in a traditional way. Okay, and I'm not going to belabor this, but the point here is to kind of smooth all of this down, get this anterior ledge especially down, and smooth this out. And I'm going to spend a few minutes and get that nice and clean. So I want to be able to see. Spend too much time of our time, but now I can go ahead and also position my flap, rotate my flap down. Actually, we were noticing here while Peter was working, I didn't see this earlier. There's a ton of scar tissue up in the nasal vault on this patient. Something happened here that I was not aware of, and I was not involved with. So now we've got our flap here, and we've got a beautiful piece of tissue, and we can rotate this around and rotate it up and place it over this raw bone that we're creating. And again, with more length, taking it down into the inferior turbinate, we can actually make that wider as well. I actually intentionally made it a little bit narrow because of some of the other procedures we're doing here, but you can actually make this quite wide as well and bring it all the way down. It's beautiful, healthy coverage for the anterior wall of your sinus to get this mucosalized, and it heals in very, very quickly. The other thing I should point out, though, when you do this is that you should drill this bone down. After you've lifted your flap, drill this bone down. Don't leave a lot of bare bone here. The reason for that is it just will not heal. When I was first learning how to do this, I made that mistake, and I still have a patient who comes in with crusting all over this area here years after the fact. And this area, you basically do it just like a DCR, drill it down to the periosteum here, and take it all down to periosteum, and you'll have no problem with healing. It'll heal beautifully, and you don't have to worry about injury to the duct. You just stay out of the duct here and just use your diamond burr and take all this down. All right, that's our draft 3.
Do you find that you need to use that flap bilaterally to resurface?
I do.
Okay.
Yeah. So I do sometimes, but not all the time. I'll do a unilateral sometimes, because you can get a fair bit of tissue just from one side, but it's really not hard also to just do it as a bilateral as well. I didn't do it as a demonstration here today, but you can do a bilateral, not too challenging. You can see how it's nicely covering that area anteriorly for us.
You mentioned using a stent to keep it in place. How long do you keep that in place for?
So, the amazing thing, and I don't know if this has been your experience, I find these things heal in like super fast. When you cover bare bone with nice vascularized tissue, same thing in the pituitary. It just seems like it seals in very, very quickly. So I almost think like the stent is kind of unnecessary in a way. But so I think that but I feel, more confident when I place the stent. So I tend to use a Propel stent just to, have some. I like the way the Propel kind of fills that area and pushes just some gentle pressure against the mucosal graft. So it's not a real heavy stent, but I think doing something is probably better than nothing. But I don't think it's a huge issue if you did stent. You can see the surface tensions wanting to hold this thing very nicely already, right?
Right. Nice.
All right. So the other thing I wanted to show you, I had already done let's go to the xeroscope. I'd already done the start of the pituitary, or start of the sphenoidotomy and everything on the opposite side, on the patient's left side. And I left it intentionally undone on the right side. And I wanted to kind of show you my approach, how I start to kind of connect the dots and actually open things up for a transsphenoidal hypophysectomy surgery. Okay, so in this case, what I've done already, and I'll just show you a little bit here. So here's posterior ethmoid section. Now, I typically will remove the middle turbinate from my on one side for my pituitary surgery. And the reason I do that is because I find it easier to just lift my nasal septal flap if I have the turbinate out. So that's the reason I do that. It just gives me more room. And I think for an educational standpoint for my residents and things, it's just easier to do it that way. I don't have to necessarily do it, but I do. So the turbinate is gone here. We also removed, of course, for our draft 3. And what I will do, here's our superior turbinate here. And what I started to do is I identified our ostium, and I started to lift my flap from the ostium. And there's the ostium there. So what I do is I tried to do what a rescue flap here.
Dr. Howe's got the beginnings of the nasopharyngectomy, so that's been, he's going to, I think, continue on with that. Looks like we're back.
Yep. Ill-timed computer crash, but I think we've got it. Looks like we're pretty close.
All right.
All right, let's try this.
All right. Back in action. Dr. Senior, can you hear us again? He's doing some hard work with the kerosene right now. That's
right.
All right.
This is all going to get edited out and pretend. No, this is fortunately we still get to see Dr. Senior working. So just audio effects notwithstanding, creating our common sphenoidotomy.
Yeah. It looks like he's removing more of the inferior part of the sphenoid sinus on the right, and he's removed a good amount of the medial part of that keel. I've always found that keel to have technically like two components that'll separate in sequence. So I usually think that lower part that he was disconnecting is always the first part, and then there's a part on the top that you're able to also kind of fracture off. Have you found that to be the case, Ted?
Yeah, I do. Yes. And oftentimes I'll find it'll fracture off, but then the piece will fracture off so perfectly that it's challenging to get it out of the nose because you have such a large piece of keel that has sort of come off one piece. But yes, absolutely. And the other question I was going to ask you is, Dr. Senior talked about it a little bit. How do you manage turbinates, middle turbinates with your routine pituitary approaches? Because I've sort of come to what I think works in my hands, but I'm curious what your approach is.
Yeah, it's a kind of along the same question that you asked earlier about whether you know there's any concern regarding resecting it. So I actually trained with removing the middle turbinate, but it's very helpful for access and also for having a graft at the end of the case if you need one. I've actually moved towards not resecting it in most cases now, just because I feel like we can work on it pretty effectively. And so I would reserve it for if we really needed tissue. We would take it without hesitation if we needed it for access, especially for larger, more extended approaches. But for the routine standard pituitary, I've been generally just leaving both of them.
Yeah, I found that I like to take it. Oh, great. Perfect.
Oh, sorry, Dr. Shannon. You sick of hearing us talk? Just kidding.
No. I'm learning. It's good.
Did you catch the sound effects?
I didn't catch the sound effects. We lost it.
You'll enjoy it. Well, good. Well, we're back with you. So
you saw that I've just been enlarging this right sphenoid now, and I'm just taking the keel down, or the rostrum down, and connecting the dots here on either side. Kind of straight to Blakesley, a big one. And I like to, and I can just kind of crack this off oftentimes.
We were just talking.
And again, yeah, exactly. And that's exactly my experience as well. Here, I apologize. I'm stripping more lining here. But this sphenoid is not super pneumatized, so our anatomy isn't great here to illustrate everything. But we need to bring that down a little more to get the kerosene down.
So watching you do this and looking forward at the posterior aspect of the cribriform and the olfactory fibers makes me think, how do you counsel your patients about potential smell sequelae of transsphenoidal surgery?
Yeah, so it is a real issue. I don't spend a lot of time on it because I don't find it to be a common sort of permanent issue with my patients. I do mention it, but I don't emphasize it. And I have to be honest, I haven't seen it truly be a big issue when we do it the way that I'm doing it here. Mm-hmm. So I think patients can get through this surgery safely with very little morbidity related to sense of smell.
Where do you define your cuts to basically protect the olfactory area?
Yeah, I tend to, I'm being aggressive on this demonstration here, but I tend to leave about 7 millimeters. That's kind of 7 millimeters. That's eyeing 7 millimeters of tissue at the superior turbinate on both sides. That's my goal, because I think that's what the literature supports us doing, to preserve olfactory tissue up there. That's where it's densest. So that's what I'm going to try to do. So I was trying to remove the rostrum here in one blow, but it doesn't want to rock on me, so I'm going to have to drill it.
I was going to ask, if you have a tumor with significant suprasellar extension, do you feel like that alters your ability to preserve those olfactory fibers in that area?
You're right. I'm going to have to be more aggressive. Yeah, I'm going to have to come up higher, right? So it is a bigger risk. I wouldn't deny that. But still, you know how it is. I can still say that I don't see it, again, as a common permanent thing. Of course, our patients complain about it acutely. It's a very common thing acutely. But as a permanent complaint, I don't see it as a huge issue for a lot of my patients. And honestly, I can't remember the last one who did, truthfully.
Which drill are you using now?
This is a 15-degree diamond. Again, at 30,000 RPM. And it's the mushroom shape.
Hmm. Do you routinely remove all of the septations?
In the sphenoid itself, only if I create a flap, if I'm going to make a flap, place a flap, then I will. But I don't necessarily do it for my routine cases. But I do, of course, take the inner sinus septum back all the way. And I also tend to want to bring this edge here, this lateral inferior edge, down as low as possible, because that makes the inset of my pedicle flap a lot easier. So I'm going to make sure that but that's also the sort of the most dangerous area, right? Because that's where we're going to catch the artery. So we want to be super careful as we come down right in here and bring it down as low as possible. All right, so we're here. We're seeing the face of the sella. We're getting the, and this bone, I would spend more time drilling this. I'm not going to belabor it here today, just for demonstration. But this bone obviously will come down all the way. But we're seeing this is flavus here. This is the sella right behind here. Again, very poorly pneumatized. We're not seeing a real prominent clival recess here, but this is it here. And in this case now, I will strip the lining out of the sinus. At the very least, again, if I'm doing a flap, I'll try to be very aggressive about stripping it. If I don't have a big leak, if I don't have a need for a major reconstruction with a pedicle flap, a high flow leak, big defect, then I'm just going to either do, if I don't have any leak, I may not do any reconstruction. But if I have just a small leak or a small defect here, I'm just going to use a free graft over this area. And my preferred free graft personally, again, is I love floor grafts. I'm a big fan of floor grafts. I use them for everything. And I just like the pliability. I like the amount of tissue you can get, and there's zero morbidity from it. Patients do exceedingly well. And you can cover this area very, very nicely here. No problem with a floor graft.
Totally agree with you. Great piece of tissue. Would you also do this approach for some very, what do you call it, dysfunctional sphenoid sinuses for inflammatory disease?
Yeah, so I do. Yeah, I do. I call it the sphenoid rescue procedure. I don't remember. I don't know if I think that's a name someone put on it. I can't remember. I think Don Leopold described it initially. I don't remember if that's what he called it, but yes. And I've actually found it to be pretty helpful. So, I find it I'll do it for my, these T1 type inflamed sinuses, patients with chronic bronchitis, maybe the older smoker patient that has kind of pus and crust in their sinuses. It's in their maxillary, it's in their sphenoids. So in those patients, I'll do this approach. The one thing I would remind everyone, though, you oftentimes do experience incisive canal numbness when you do this approach, right? So you'll get premaxilla numbness because you catch the nerve as it's coming down here in front of the sphenoid. So I do this approach, and I have found it to be helpful very commonly, similar to doing a medial maxillectomy, endoscopic medial maxillectomy on those puffy maxillary sinuses as well. So I'll do the endoscopic medial max, I'll do the sphenoid rescue, and I would say a very large percentage of patients do get significant benefit from it. It's not perfect, but it absolutely seems to improve things in a vast percentage of patients.
Dr. Senior, one issue I've noticed in my hand sometimes when doing the sphenoid rescue is that the sphenoid sinus will clean up, but patients will still have an issue with some chronic crusting at sort of the posterior septectomy where the entire bilateral sphenoid and that small posterior septectomy come together. Perhaps to like an air scoop effect. How do you, are there any kind of insights or tidbits that you have to prevent that? Or when you're designing this sphenoid rescue, how do you think about airflow to prevent that?
Yeah, you're right. I do see that occasionally. Honestly, I think about it kind of the same way you do, and I'm actually looking at it kind of thinking about how to reduce that scoop effect as much as possible. You're right. Sometimes it isn't possible to make it go away entirely. And I don't have a real easy solution there other than to keep drilling. And you're almost taking the entire floor out, when you do that sometimes to try to reduce that. And I have done that in a couple of patients where I've drilled it back pretty far here to try to really create just kind of a smooth kind of cavity that's less likely to kind of have that air trapping and that airflow issue like you're describing. Also, though, I have to say, I use xylitol saline rinses, and I think that helps also. You get less of that crusting with the xylitol. I've seen some. In fact, I saw a patient just the other day. She was crusting forever, and I put her on the xylitol, and she's completely clean now. Amazing.
Yeah, I agree. I've actually had several patients tell me that I need to be recommending xylitol to everybody for similar reasons. So I too have been using a lot.
All right, so we have a beautiful view of our sella right there. We have the optic carotid recess, again, not well defined because of the underpneumatization of this cavity. We got the carotid artery here, optic nerve here, carotid artery under this septation here, optic nerve above, sella here, and this, of course, is where we would drill and we would get our exposure to the anterior clival indent end. And again, I would bring this little ledge down. This obviously has to come down, but this is a big rock of bone. It's going to take me several minutes, so I'll go do that. Okay.
Great.
Yeah, that might be a good transition to go back to Professor Howe. That bony work and then I've got
my maxillectomy started here. I was going to show you that. I'll do that after you guys come back again. And we started with a little. I started on this side with a Denker's approach, so we'll kind of combine that with our maxillectomy when we come back. Okay.
Wonderful.
Perfect. Professor Howe, we're back with you.
Yeah. So let me back to our case. Here, I chop away the lateral pterygoid plate, which is depressed medially, and then you could see actually the eustachian tube is here. The eustachian tube is here, and this is the sphenoid sinus. I actually removed most of the sphenoid sinus floor. So when you retract the mucosa down, you could see a very beautiful pharyngofacial fascia attached to the facial occiput here. And you really need to cut the fascia and use this fascia as the margin for the dissection. Yeah. So here's the lateral pterygoid plate. And then, so I just cut this, and then we check everything down. And here's the tensor paracardial muscle. See that? It's very paracardial muscle, and the eustachian tube has been cut somewhere here. I think this is cartridge. And then actually, when I move the, so this is the data pterygoid plate, and I have been using the Bovi to cut the mucosa cut, the inferior mucosa cut, the data mucosa cut over the inferior torus tubaris, and then to the contralateral. Usually it's right anterior to the contralateral those aminofossa, and then we just connect everything here, and we typically just remove this tissue. So we have a very good control of the surgical margin, and remove everything here. And then that will be the most difficult part of the surgery, because the specimen is attached seriously to the pharyngobasal fascia. You really need to detach the fascia from the basic occiput, and it's the top. The fascia is very tough, and you got to cut it. And so sometimes I use a collaborator. However, if permits, I would love to use a pinpoint electro cutter so that you could cut the mucosa very precisely. So we nearly finished the procedure here. Yeah. So I will just continue. Is there any questions?
This is really beautiful anatomy, and you can see it really well on your image guidance as well. With regards to the eustachian tube, and just from all of these areas, are you always trying to use energy devices for making the cuts, or do you ever make any of these cuts using cold steel?
It would be better to use cold steel, use a cold instrument. However, you see that's the pterygoid plate base. The pterygoid base. Usually, you see a lot of vein coming down. Is actually the pterygoid plexus, which is continuous to the cavernous sinus, the lower portion of the cavernous sinus. So, in living people, this area will breathe a lot. You will lose your field. So you see a lot of venous blood here. Yeah, so that's the most. But I would love to. Step by step, and so it really needs your assistant to retract the tissue down, and you use a pinpoint electro cutter, and then step by step just cut it and push down, cut it, push down, and until you meet the longus chori. You remove all the pharyngobasal fascia, meet the longus chori, and try to stay outside the longus chori and to complete the procedure. So here you see the later. I'm going to remove this, and you will see the later cross of the torus tubaris. All right.
Yeah.
Okay.
And then one other question is you usually do a posterior septectomy
yes.
for these? Yeah.
Yeah, do a later septectomy so that you could use two hands, two people, four hands technique, and so that you could see this is from the patient's left nostril, and you could use the scope here, and your assistant check the tissue medially, and then you have a clear cut over this area. Okay.
Got it.
So that's really help. That's really help. So that's part of the so-called create the corridor. You know, you really need, because it's very down deep in the center of the skull, you really need to create a corridor before you do any surgical dissection. Yeah, that's very to provide good enough wall field so that you could really see the whole nasopharynx. Yep.
Great. What is your?
Sorry,
go ahead.
I will continue.
You first.
No, I was just going to ask what Professor Howe's next step was, but I think you had a question, so you go first.
Yeah, I was just curious on how you counsel patients and your philosophy about neurovascular preservation with a transpterygoid approach. I know that it will vary with pathology. You know, certainly a large cancer surgery you may very well be counseling patients that they're going to have numbness of their cheek or their palate or dry eye. But say for like a lateral sphenoid approach for an encephalocele, how do you find that you're usually able to retract trigeminal branches away or work above Vidian, or basically what is your approach to working around those nerve and vessel bundles in that area?
Yeah, basically the trigeminal nerve, the V3 will be out of our surgical field because endoscopic dissection from medial to lateral, it will be very difficult to reach the foramen body, first of all. So very difficult. There's, to me, that if the lesion really involve the foramen body, I will do a combined approach, a subtemporal approach with endoscopic approaches. And then for the V2, it's possible, but it's very far away from the current dissection. Do I have a retractor? It's very far away from usually the lateral pterygoid plate would direct to the foramen rostrum here, and so it's kind of far away. Of course, you could follow the V2 from this area, from the transpterygoid approaches. You find the Vidian and you find the V2 here, and you could trace it. Yeah, you could trace it.
With a transpterygoid approach, say to like a middle fossa encephalocele or a lateral sphenoid encephalocele, do you find that usually you can reflect those down and out of the way or work above Vidian, or does it depend on sort of the dimensions of that space?
Say that again.
Well, like if you were working more laterally, I was wondering how you manage working around V2.
Yeah, so that's V2. Most of the time, you don't need to touch, and if you see the V2, you could actually drill the bone over and trace it to the foramen rotundum and preserve it. And unless the patient would have preoperative numbness of the cheek, and then there is no reason for you to really sacrifice the V2. But in my practice, there's really have any problem because we kind of limited our endoscopic resection to, to just remove the medial pterygoid plate and keep the V2 just, I know it's somewhere there, and I just keep it intact and don't touch it. Yes.
Great.
Would I answer your question?
Yes. Yeah.
All right. And your next step on the nasopharyngectomy is what at this point?
Sorry?
Oh, what is your next step right now that you're going to do next?
Oh, I'm going to define more on the escutcheon tube and try to go as lateral as possible. And so that usually we'll see we could, we could actually drill a bone here between the Vidian canal and the V2 and drill the bone here, and that will give you a better access to the escutcheon tube, especially laterally, and that's very, because in our case, if they recurred after the endoscopic nasopharyngectomy, they have a recurrence here. So you really need to send frozen to control the lateral margin here. So you really need to remove as much bone as possible here and resect the escutcheon tube as far lateral as possible. Yep. So I'm trying to do that. Yep.
Oh, okay. So in that case, while you're doing that, we'll briefly go back to Dr. Senior first, and then we can join back when you have more of the specimen ready for delivery.
Okay, you hear me?
I hear you.
Okay, so what I've done on the patient's left side here is I've started a prelacrimal approach to a maxillary sinus. So when I do
It's not
this,
working.
I sort of have, I want to have a visualization. I've created an antrostomy here, middle meatal antrostomy, and I'm going to visualize where the roof of the maxillary sinus is located. I'm going to start with a little incision here anteriorly at that level of the roof. That kind of gives me an idea of how high I can take my prelacrimal approach to, how high it can go. And I've brought the incision down along anteriorly here along the piriform, just piriform, just anterior to the, or just behind the actual piriform margin here. And I bring it down onto the floor because I find it helpful to have a fair bit of tissue to reflect. It kind of makes it relaxed, right? So my incision is in front of the inferior turbinate from about the level of the orbital floor down onto the floor of the nose. And now I'm going to start lifting it. And as I'm lifting, obviously we're getting into the inferior turbinate. And I'm going to go ahead and start. I actually resected already a little bit of the root of the turbinate right here. I took a kerrison and I bit at this root right here. And then I swept back, kept sweeping back in the inferior meatus, kept sweeping back over the top of the turbinate. And what that does is as you're doing this, you're pulling the nasolacrimal up into your flap, right? You're protecting your flap from underneath here. Mm-hmm. And so now I'm having a 0-degree access into the maxillary sinus right here. And we just popped right in, actually, as I was using my kerrison and my little coddle, it just goes right in. And then I just started enlarging it a little bit with my drill. And I can take this up. I know how high I can go here, and I can take this up safely, and I can keep working this to get a nice big exposure in this area. Can I have that, Karis? And this is really a helpful approach for these anterior-based lesions, you know, these anterior inverted papillomas involving the anterior wall, where you really can't see where the attachment is here, you know, from a middle meatal antrostomy type approach. So it's really nice to be able to kind of be able to look in here anteriorly. Again, I'm doing this right now with a xeroscope, and you can see how much we're seeing. And as I enlarge this and bring this down onto the floor, and drill this all the way open, we're going to get a beautiful view of the anterior wall of the maxillary. We'll be able to see over to the lateral wall with this 0-degree scope. And the thing that's amazing, always amazes me with this approach is, you know, after we're done here, we get the tumor out and we go ahead and put this, and it looks like you didn't do any surgery. I mean, it's amazing how intact everything is. And this is the difference from the dankers, right? So the difference with the dankers is that you're removing all of this, right? We're going to do a maxillectomy, and we're going to remove and take it all the way anterior into the piriform aperture. And we're going to take the turbinate, we're going to take the nasolacrimal duct, right? We're going to get that good exposure, no doubt. But all of this goes away, and so it is a little bit more aggressive, but it gives you a similar view. And this is a little bit more preserving of the tissue. You're preserving more of the structures in this with this approach.
What might be a situation where you would choose the dankers over the prelacrimal approach?
So if you want, especially post-op observation, to be sure that you're having a good clearance of that area and monitoring that area, you do get a better post-op view with the dankers, in my opinion, to be able to monitor that. So that's one consideration that I have. Obviously, a dankers is again better for more aggressive resection, whether it's a more aggressive recurrent inverted papilloma, something like that. I would probably consider that as well. That has been always one of my concerns about the prelacrimal approach. It absolutely works. You get that beautiful exposure, but my post-op observation is always a little bit limited. So it does make me kind of oftentimes favor doing a more dankers type approach.
When you do the prelacrimal approach, for surveillance, does that change how you would use imaging? Are you more likely to get an MRI in a certain interval?
It's a great point. I don't have that in my mind as a standard thing, but I have a sense that I probably, if you looked at my patients who I've done this to, I probably do imaging probably a little bit more commonly in these patients. So I can say, like, I did, the last one I did of these was like with a big anthracoina polyp. It gave me a beautiful view of that anterior wall. I don't really worry so much about a recurrence of tumor in that area, right? It's not a tumor that I'm dealing with. So again, I think that's kind of a perfect application for this. If I'm doing a medial maxillectomy for something, then I'm doing a Denker's. That's what I'm going to, right? You can't do a prelacrimal with a medial maxillectomy. You're going to do a Denker's. You're going to want to take all of that tissue, finish taking the head of the inferior turbinate, and just cut the nasal lacrimal sharply. And I feel that's a safe and effective approach.
We have a question from the audience, Dr. Senior. So, do you have any tips and tricks to minimize numbness of the upper teeth and upper lip for the premaxillary or the Denker's approach? It's a common concern with the anterior superior alveolar nerve. So, just wanted to see if you had any thoughts.
No, you know what? Honestly, it's counseling. You're exactly right. It does happen. And I just warn my patients. I tell them to kind of expect that it's going to happen. So I think I don't have any great techniques to avoid it, though. I kind of expect that it is going to happen. You're right. So on the opposite side here, I've already started my piriform aperture incision again. And in this case, I'm going to go ahead and do the medial maxillectomy, and then we'll connect it up with the Denker's. Let me go ahead and go ahead. You had a question?
Yeah, I just feel like, just to follow up with what you had mentioned, a lot of times that does tend to recover over time because there have been studies that show reanastomosis. It's a pretty rich network of small nerves. So
I agree.
It's like you said, counseling and giving it time oftentimes is very adequate for that.
Yeah, exactly. I agree 100%. It's honestly, you see similar type things with septoplasty and stuff when you're doing an aggressive crest resection or something. So
right.
Again, it's counseling and it comes back.
Mm-hmm.
So I'm just doing a maxillectomy here on this side, taking the inferior turbinate. Nice thing about these dissections in the lab is they don't bleed. Because it bleeds.
Yeah, this part that you're doing right now, especially.
Yeah, exactly. And of course, I always have my suction cautery ready to go back here. So that's our turbinate out of there. So now I like to lift a little flap here underneath the inferior turbinate when I do these cases. Because what I'll do is I'm going to drill all this bone down over the maxillary, over the medial wall of the maxillary, and I'm going to use this little mucosal flap to kind of drape over the raw edge. I like to cover my raw bone. It's the bottom line. I'm constantly trying to figure out ways to cover the raw bone that I create. So I've gone ahead and just made a couple of incisions. I tend to do this with a needle tip cautery. And
it's like you said. It's like you said with the slap flap earlier. This flap heals so quickly and so well.
It does. I agree. So here we can actually see into the maxillary. Here you can see a little bit, and magically we can enter the sinus very easily here. Now, we can try to, let's go ahead and just take this out. We can try to identify our nasolacrimal right now. It's okay if I don't get worked up about it right now, because I'm going to try to cut it and identify it later on.
Mm-hmm.
So I don't worry about injuring it or anything inferiorly at this point because I know I'm going to. And I'll get straight to cut, please. Okay. And take the drill. And we'll take that down now. And again, the Denkers is simply a continuation of the medial maxillectomy, right? It's taking it up to the anterior wall. And again, we'll take this all the way down to the floor.
What are your thoughts regarding a Denkers or a prelacrimal versus a Caldwell-Luck?
I hate Caldwell-Lux. I think there's few operations that I find that we do that cause more morbidity for patients. Patients hate them, and they cause all kinds of problems, and they all get numbness, and they get, they have pain. And I see these patients that had Caldwell-Lux 10 years ago, and they all have facial pain and such. So I just try to avoid them. I mean, of course, you can continue your Denkers onto the anterior wall and expand it into the anterior wall, and you're essentially getting close to a Caldwell-Luck, right? But I really try to avoid a sublabial incision with a traditional Caldwell-Luck. Can I have let's have the backbiter.
And we see that you took the medial wall down all the way flush to the nasal floor.
Yeah, and in fact, I would take this. Oftentimes, I'll do more than this. I'm trying to be fast here, but I will actually smooth it out so there's no lip here at all, and try to really make it confluent with the maxillary. I find that very helpful in general to do that, especially for these inverted papillomas and things that I'm trying to treat.
Yeah, there's usually that little bit of maxillary that sometimes for some patients with actually very large volume goes almost a little medial to the floor.
Correct. Mm-hmm. Yeah, it's crazy sometimes actually how pneumatized it can be and how far it can extend there anteriorly and how medial underneath here. So yeah, I recommend taking this all down, and I would definitely drill this more here. But let's go ahead and show how we do. We're up against time, I guess, right now, but let me just show real quickly what I do here with our Denkers. So I've lifted this off, and we're going to, just again, like our prelacrimal, we're going to lift all this and take it all the way back. But in this case, we're taking it all the way back to the actual maxillectomy defect here. We can lift this up out of the way. And I would do an inferior, I didn't make an inferior incision here, but I'll oftentimes lift this flap up and just kind of tuck it away like this while I finish the bony work here. My flap is getting a little amputated here, but we're seeing, there's our duct. There's our duct.
Yeah, this mucosa is always very challenging to elevate because of the inferior protuberant contour.
Exactly, it is. So our duct's in here. At least I think it is. Well, let me go ahead and what I'll do now is I'm going to drill all of this down. And again, the goal again is always the same. It's just to be able to see with a 0 degree scope to be able to see all this anterior wall of the maxillary. And in this case, coming from the piriform all the way back. So we can sweep that up and out. Okay.
How often do you think epiphora is long-standing after Denker's approaches like this?
Very uncommon. I really do take time to try to see the duct and dissect the duct, and I try to sharply dissect it when I'm done with everything, sharply cut it. And in my experience, it's been very, very uncommon to see any sort of long-term issues with epiphora. What's your experience?
Yeah, I think it's very unlikely overall. I think temporary epiphora is probably from edema, and then they usually do patients can do some massaging, and then over time, I think long term, it's not that common at all.
Yeah, I think that's exactly right.
I agree. I think it also depends on how close you ask. I think that sometimes people may have some subtle decreased flow of tears. Maybe there's some stenosis of the distal kind of neoampulla, but I agree that clinically, clinically relevant epiphora is very rare.
Mm-hmm. Do you fill the sinus, or how do you manage the sinus after creating a large Denker's cavity?
So I don't personally do that. I'm aware of some people that do, but I typically leave it kind of open. It depends on the purpose of what I'm doing. Usually it's going to be inverted papilloma, right? And usually it's going to be inverted papilloma involving the anterior wall. So I may use some hemostatic agents against it or something like that. But I don't generally do, I don't do all of that as a routine. I do base it on the pathology and what I'm actually, what my issues are that I'm dealing with.
Mm-hmm. And sometimes with the inverted papillomas, especially when there's a lot of mucosal strippage that's necessary for tumor resection, that sinus can crust for a while. So that's why I think some people tend to obliterate the sinus a little bit short term. With a view like this, you're going to be able to see a lot, even with a 0 degree.
Exactly.
Nice.
And now we're reflecting our duct, you can see, is being reflected up right there.
Right.
As we come through the nasal lacrimal right there. Almost there.
I feel like this part, the bone gets really firm, so then you're almost about to, you almost have to like rock it off, like grab it and rock it off with backbiters, sort of cutting through it.
And this large backbiter is really helpful for that, right? You can almost use it like a curette in a way to kind of get it to move. Get the drill.
And you routinely take these up to the orbital floor?
Depends on the pathology. I don't routinely, but I don't worry about doing it if I need to. It can be helpful, especially if I'm trying to get over to the zygoma. It does help me to kind of take it up pretty high.
Mm-hmm.
There's my duct, so we'll feel it.
Another nice advantage of these approaches is being able to access the space just lateral to the duct. And so when you distract it upwards, you'll be able to sometimes catch tumors that have crawled into that space.
Oh, I know. Isn't that awful? I hate these tumors up here, and this is perfect for that, right?
Yeah. Yes.
It really, there's no other way, right? It's no other way to be able to see. But look we're already now in front of the duct and coming anterior to the duct. So we're getting that same prelacrimal exposure that we had on the other side, but we're obviously removing everything here.
Right. All of it done with a 0.
All done with a 0. A dirty 0 right now. I apologize.
What do you set your irrigation on when you do procedures like this?
I like a lot of irrigation. I do not like to burn the bone, so I really do like a lot of irrigation. It's a pain from the standpoint of visualization like this, but it really, I think, is better for post-op healing.
Yeah.
So we got here. Suction.
So given that this cavity tends to crust for so long, especially if you have to do a lot of drilling or denuding the mucosa, what's your typical post-operative routine for these patients? How do you see them more frequently than you might otherwise for debridement? Do you, I know you mentioned xylitol before has been very helpful, but what's your approach to this kind of chronically crusted cavity?
I leave it alone. The reason I leave it alone is because it's miserable for patients to debride it all every time. So I let nature work more on these. I don't really care if there's a little scar in the sinus afterward. It's not like, to me, it's not common that it causes a functional disability in my experience. So I'm not super aggressive with my debridements, to be truthful. I let it granulate, let it heal in. So there's our view. There's our anterior wall right there. So it's really nice. And again, 0-degree scope, right? So this is exactly what we want to be able to do. And I like the Denkers. There's our duct hanging down there right there. And we would cut that nice and sharp at the end of the operation. And I would do a little bit more drilling up there to kind of clear off all the little rough edges right there. And and there we go. And I try to I'll lay that little mucosa flat back down over the raw stuff as much as possible.
That's beautiful. Thank you so much. Well, we're going to head over to Dr. House and check in with him. He's got more of the nasopharyngectomy completed at this point. Dr. Howe, can you hear us?
Yes. I actually finished the nasopharyngectomy sucker. And actually, I removed the specimen, so I just show you the surgical defect here. Here's the sphenoid sinus. And then you see we have a very great view of the second genu of the carotid artery here. The second genu, because I removed some of the bone here, and then you could see the second genu of the carotid artery here. And actually, it's very far away from the suction tube here. And you see there's some remains of the suction tube cartilage here. And then this is the tensor varipedine muscle. And here's the sinus Morgani. And you could actually keep on drilling the bone until the second genu, and you could remove all this area, and then you resect more suction tube as for the further laser extension. Yeah, so that's the complete of the nasopharyngectomy. And again, you see this is the top fascia here is the pharyngobasilar fascia. I remove it with electrocauterization and recheck the tissue down. And you see here the longus colli muscle. And then you could use this pharyngobasilar fascia as the surgical margin here, and the contralateral lower fossa here. So that's the complete of the surgical resection. And see some of the remaining E-tube cartilage here. You could go further to remove the cartilage further and to form more later extension for more surgical margins here. Yep.
Do you have any?
Yes.
Do you have any tips and tricks to share with the audience on how you identify parapharyngeal carotid in this area?
The parapharyngeal carotid, usually you could trace the carotid artery and go laterally, but it's in the parapharyngeal space. So it's really need to recheck the soft tissue down and to see, and usually we don't routinely do that. And so I said that again because that will be the transverse petrous portion of the carotid artery, and then the second genium could be located with either the Vidian canal or the. Let me try to find the. I could remove the bone here and try to find the. So foramen of condom. And you go laterally, you will find the foramen ovale, but usually very difficult to go this way because you need to remove all the, pterygoid muscle, and there is no margin here, and so very difficult to do that. And then again, because you see a lot of venous practice here, and the venous practice will go up along the internal carotid artery to the cavernous sinus area. So usually this area you will do so your surgical field. So very difficult to locate. If we want to locate the first standing of the carotid artery, we typically will use open approaches. In my experience, it would be very, very difficult to locate the first standing of the carotid artery, through the endoscopic approaches. Of course, you could do go further here. You could go further here, but anyways, it's difficult. I think this is probably the V2.
Mm-hmm. When you've had to manage the carotid artery as part of the resection, either in an endoscopic or combined open endoscopic approach, what are some of the strategies you use to control it ahead of time or be prepared for it? Do you use embolization or do you ligate it in the neck? What do you usually do?
Actually, the patient got to pass the balloon occlusion test. We still believe that the patient got to pass the balloon occlusion test, and then if it's possible, you do open approaches. Then you could control the proximal internal carotid artery through the neck. And through the neck, and then that's very easy through the neck. And then you could then drill down and to meet endoscopically to drill all the petrous portion of the transverse portion of the carotid artery here, all the way and up to the sphenoid sinus, the vertical portion. So, yeah, but I'm kind of reluctant to do this in case of high-grade malignancy. Yeah. But for benign lesions, I think you could do that.
Back to reconstruction, if there was no nasal septal flap, how would you cover up this nasal pharyngectomy defect? What do you usually use instead?
Well, there are several ways to do that. We used to do something like a lateral nasal wall flap, and but it's kind of short. And then the other thing you could do is actually do a preauricular incision and raise the parietal temporal flap, and through a hole here, and through the hole you could bring the parietal temporal flap to cover the defect. Especially if you expose the internal carotid artery, you need to use something vascular flap to cover the exposed carotid artery. Yes, especially in case after radiation therapy. Yeah.
Mm-hmm. So you always prefer to use vascularized tissue?
I try to use vascularized tissue, but sometimes it's not available or it's really difficult. In the past, we don't really, early in my career, we don't really reconstruct this area secondary regeneration. And believe me, around I did around 10 something subtemporal approaches, and then there are 2 cases of carotid artery blowout without because I don't resurface the carotid artery. So that's a disaster for the surgeon as well as, well, it happened some months later. It's not really happened during the surgery or immediately after surgery, but some months later, and then it just ruptures. The carotid just broke out. So it's a disaster for the surgeon and also for the patient. So now I try to, if I expose the carotid artery, definitely I will try to cover it with some vascular flap. I never try to use, I don't know what your experience, I never try to use facial rata or something because, this area has been heavily irradiated and I'm just not that confident with some vascularized tissue, vascular tissue to cover the defect.
Do you ever do nasopharyngeal? Oh, sorry, go ahead. You're finishing up.
Yeah, so and then again, if there is no bone exposure, there is no vascular exposure, there is no internal carotid artery exposure, it is there. You don't really have to expose that. You need, if you expose that, you really need something to cover. So, it's there. It's your safety margin. You keep it away, and then that's it. And if once you expose it, you drill the bone, you got to cover it. And that's really a problem. Yeah. Yeah. So, any more questions?
Yeah. My other question was: do you ever do this approach or for radiation necrosis, where there's a breakdown of the soft tissues or there's exposed bone? And do you have any tips to share with us about your experience with that?
Well, I did. I actually published endoscopic secretectomy for skull-based osteoradial necrosis in laryngoscope some 20 years ago. And I guess I'm one of the earliest surgeons to use endoscope to treat the osteoradial necrosis. And then the key is to have a very good, local hygiene. So we did a lot of, local treatment or debridement nearly every week. I try to keep the, very good hygiene. And then, but then again, the extent of the resection, to secretectomy for the diseased bone is really very, very difficult to decide. But then again, it's very, very terrible because most of the cases were actually there was cases after 2 courses of chemoradiation therapy, and then. And I do have some other cases who the defect was reconstructed with pre-prep. I worked with Fu Chunwei at that time in Changchun, and so they are very good plastic microvascular surgeons. So they raise the flap and to cover it, and then some other flap we try to use is the splitted temporalis muscle flap or the parietal flap to cover the defect. But then again, to control the osteoradial necrosis is you really need to improve to keep the local hygiene. So you really need to do a lot of suction, daily suction or weekly suction, try to clean the defect, try to keep the hygiene for the defect, and then the osteoradial necrosis, they won't progress. Yeah, I think that's the key issue, and we have been very successful to keep the patient, and then after we did that, little chance for them to develop carotid artery blowout. Yeah.
Great. Thank you so much. And this is, again, I think nasopharyngectomy is beginning to get more and more widely adopted all over the world, so that we're always looking to learn from experts who have a lot of experience like yourself. I know, especially in Asia and Taiwan, especially, has a very endemic population of this disease. So thank you so much for sharing that with us.
Well, thank you for the opportunity. Thank you.
I have one comment to the audience or call for questions, and then a question for Professor Howe as well. I would say to the audience, if you have any questions for our experts, now's a perfect time. We've got 2 dissections going, and certainly if there's anything that you want to see in more detail, or questions that you have, or something else that you want to explore, now's a great time to do it. And Professor Howe, my question for you is we've as these endoscopic approaches have gotten more and more sophisticated, in your practice, what is the role for open midline approaches to the nasopharynx, like a maxillary swing or mandibular swing? When do you still fall back on those?
Well, actually, I have to confess that I did that very rarely, very rare now, and so most of the T1, T2 recurrent case, or even some of the T3 recurrent case, has been managed by endoscopic approaches. And however, we still do open approaches, especially for some lesions, not really for recurrent NPC, but also for some of the myosalivary gland tumor, myosalivary gland cancer, such as adenocystic carcinoma. And for adenocystic carcinoma, there's a pseudo capture, so that would be much easier to have a surgical margin on that. And in that sense, the resectability would be more feasible to improve some of the case, to get into the infratemporal fossa or even the subtemporal fossa, and so that you might use a combined external approaches with the endoscopic approaches. But for recurrent NPC, again, the opportunity to do open approaches has been very, very few now, and it's most likely because of the very good control of the local by the improvement of the chemoradiation therapy. And then again, in Taiwan or in Asia, in Hong Kong or in Singapore, we use a lot of EBV marker as a biomarker to monitor the case during or after the chemoradiation therapy, so that we really could to detect early recurrence. And then that's using the free DNA, free DNA load. You could easily find out some of the early recurrence or persistent cancer, and you could have an eye watch on them, and once they have recurrence, you did nasopharyngectomy for them. And actually, I have a small series of 12 patients underwent endoscopic nasopharyngectomy, and they all developed within 6 months after surgery, and 2 of them, although the preoperative, after radiation therapy, the preoperative biopsy was positive for NPC, positive for cancer. However, after the permanent, after nasopharyngectomy, they could not find any tumor, and then has been also approved by the EBV DNA load, which returned back to 0 and detectable. So that's also the molecular evidence that you really eradicate the disease. So that means if you really use some biomarker, really really detect the lesion early, and you could very possible to control the disease. Yeah.
That's great. And one other question, just take the opportunity to ask you, as an expert who's really seen the progression of open approaches to endoscopic approaches, and now these blood tests that we can use to detect earlier recurrence and use these endoscopic approaches. What do you see on the horizon? What are you excited for? What do you think the next step in management of nasopharyngeal carcinoma is going to be?
Well, you see, the Sun Yat-sen University in China, they actually published a large series on the nasopharyngectomy with advanced cases, and then some of their cases actually they removed the internal carotid artery and graft the artery with some material with long venous vein or some other venous structures, and they have very good equivalent disease survival with the second IMRT. So that means, although we do most of our endoscopic procedures for early recurrence, but still there's a place for the advanced case. If you could really control the internal carotid artery. However, in our experience, we're kind of reluctant to do that just because we think if you resect the internal carotid artery and graft the internal carotid artery, there's a high chance of the patient to develop some neurovascular accident. And then if the patient really wants to do that, because in our experience, if it's the internal carotid artery need to be removed, then the patient, around 30% of the patient will develop distant metastasis within 1 year. And so I think we are kind of reluctant to do that kind of surgery. I mean, to remove that will probably, in my mind, that will probably too much to remove the internal carotid artery, especially if it is just for septic margin. Yeah.
Have you worked with 3D endoscopy, or do you see a role for robotics in accessing this area?
Yeah. I think I'm one of the reviewers for Jason Chen for I forgot the name of from Hong Kong, and they advocate that they use the 3D endoscope, and they find that they have a clear view to dissect around the internal carotid artery and really facilitate for their dissection and for their grafting of the reconstruction as well. But it's just not our experience. Yeah.
Great. Thank you so much.
I have no experience.
You have much experience.
So at this point, really want to thank our honored faculty for walking us through some very challenging and very advanced dissections and for sharing their expertise with us. Dr. Senior and Dr. Hao now in the same screen together. So we want to just kind of debrief about everything. Dr. Senior, do you want to start and just kind of give an overview of just some general tips for the audience on some of the work you've done today so far?
Well, I think the key is honestly looking at your CT scan. I don't like to be surprised in surgery. And so I spend a lot of time really studying my images and really understanding the anatomy, understanding what the pathology is that I'm dealing with. And doing it in a systematic fashion, I think, is really critical as well. So, it seems like a minor thing, and it seems like a junior resident type recommendation, but really it's super, super important. Spend time with that imaging, really study that imaging, know what you're dealing with, know your anatomy, know your pathology.
It's such a core concept that you bring up, because it always comes back down to the anatomy to be able to perform these procedures not only safely but effectively. And I just really loved how at every point in your dissection you're planning out the next steps, and not just from a technical standpoint. You are also thinking about the post-op. You're thinking about long-term surveillance, thinking about medical therapy. So it's a very multi-dimensional introduction to each of these procedures.
Yeah, 100%. Absolutely.
I really think it makes a lot of sense too, even as a very experienced surgeon, to use a regimented, structured approach to reviewing anatomy, because it's so easy to just overlook something in a busy day. But if you go through that mnemonic or you go through that system, it really forces you to do so. So that's certainly one thing I learned from Dr. Senior, and I think it's very, very effective.
And then Professor Howell, again, this is one of the most challenging procedures we can perform. So, yeah. So please share
it makes it look easy, though.
No, come on. Well, I just want to echo what Brent said, what Professor Senior said. Looking into all the details, study your imaging beforehand and decide the steps for your nasopharyngectomy, for your skull-based procedures, and define step by step what you're going to do. What's the anatomy you need to find out, and you find out all you need to find out, and then the tumor will be very easily out. So I guess that's the basic procedures. There's no fancy stuff. Everything is just fundamental.
Yes.
The anatomy and the imaging study, and then some of the surgical technique as well. But we came all the way, and I'm not an expert in doing this. But anyway, well, if you are familiar with the anatomy and the imaging, then certainly you will be there someday. Yeah. All right.
Yeah.
Fantastic. What wonderful opportunity. Thank you both so much for participating. I want to again thank our industry sponsor, Medtronic. Obviously, the facility today and the AV was really great, and we got a great sense of what was going on. So thank you all for participating, and hopefully this will be the first of many future similar international events.
Well, thank you for the opportunity, and it's a great opportunity for me. Although you come along very far away, and however, we have a very happy ending. I'm very happy to work with you guys, to work with the Medtronics, and to work with my partner here. Will you come into this?
Oh yeah,
come on.
Let's
Come on. Yeah, actually, the last cuts of the pharyngeal fascia were made by Tesla, right? Yeah, so really a good helper and all the stuff. So
yeah, I just wanted to give a shout out to the team here at Medtronic. Has been fantastic. They have really helped us tremendously. Thank you, guys. Really terrific. Thank you. AV is sitting in the back there doing a great job. Really terrific first rhinology around the world session. And I want to thank you, Ted and Ed. Wonderful job moderating here today.
Thank you so much.
Thank you.
And again, for the audience, if you have any feedback, you'll always reach out to us in the ARS, and look forward to additional topics of interest as well. I think that's a wrap for us, right?
That's it. Have a great night, everyone, or a great day.
Have a great day or night. Thank you all for being here.
Have a great Christmas.
And Merry Christmas.
Oh yes.
Merry
Happy
Christmas.